Hi, good afternoon, everybody. This is Dr. Eileen West. I'm a general internist in Fairfax, Virginia. Welcome to our Facebook Live presentation this month. I'm very excited to welcome Dr. Theresa Soto, who works for the Center for Vein Restoration. And she is here to talk with us and answer your questions all about varicose veins. So jump on the chat, ask us some questions. She's going to do a little presentation to start us off, and then we'll be available for questions afterward. So thanks for joining us and for tuning in today. We're happy that you're here. So Dr. Soto is graduated from SUNY Buffalo Medical School with an Air Force scholarship, and then was selected to do obstetrics and gynecology residency in Buffalo, New York. Her first assignment as a new physician was as a captain in the Air Force in Texas during the time of Desert Storm. She served in several roles there and did some really neat things, which she might want to tell us about later. She began working in Northern Virginia in 1999, practicing obstetrics and gynecology in Fairfax County until 2013. She then decided to complete additional training in the field of venous and lymphatic medicine and vascular interpretation, and thus began a whole different new career journey working with people with chronic vein disease. And I think in particular, what's interesting and appealing about having an OBGYN who's done this is that she actually can address some pelvic vein issues that reach up into the pelvic area and manage pelvic pain that way as well. So it's pelvic vein of venous origin will be one of the things that she touches on. So welcome, Dr. Soto. We're really happy you're here.
Thank you.
Yeah.
All right. A new format for me, but we do a lot of talking at Center for Vein Restoration because education is actually really important to us. So I'm very happy to be here. This is exciting. All right. So get our slides up there. We'll get started.
All right. There we go.
So as Dr. West said, I work for Center for Vein Restoration. I do a lot of different things at CVR. I'm a physician in the clinic. I'm a pelvic pain consultant for Center for Vascular Medicine for our patients who come in with pelvic pain, and we find that it's actually of venous origin, so something different than what the gynecologists do. I work with our fellowship program, and I actually do QA for our company, so I keep everybody square on their charting. Vein disorders and venous disease is actually really common. A lot of folks hear that it's mainly a cosmetic problem, or don't worry about it, your mom and dad had it, you're going to get it, it's just what you have to go through. It's really, really amazingly common. If you look around, if you now look in the supermarkets when you're behind somebody in line, you see darkened skin, you see varicose veins, you see spider veins, swelling. So it is something that's the most overlooked in a lot of doctors' offices, just because you're there for your diabetes and your hypertension, and you think this is what your legs look like, so your doctor's used to seeing them, and unless you pay a little attention to them, your doctor may be busy with other things. So with 25 million people in the United States suffering from venous disease, it's actually something that needs to be paid attention to. Women particularly, 25% of women roughly will have some sort of venous disease. As we get older, once we hit 50 and 60, it's 50% of the population who have some sort of venous disease. And that discomfort, achiness, heaviness is something that a lot of women get accustomed to and just figure that's part of the deal with getting older. But there are a lot of things that are not just something to get used to, but can be actually treated, and your legs can be made to feel better. A lot of myths about vein disease. Vein treatments are not just for cosmetic concerns. Yes, you can have spider veins treated, but for tired, achy, heavy, crampy, swollen legs, there's so much we can do that is minimally invasive, and it's not cosmetic. Insurances cover these treatments. They realize that venous disease is a medical problem and it merits treatment. And just because your parents or your grandparents are now living their lives with swollen legs, big blue varicosities, doesn't mean that that's what you're destined to do. Our moms and grandmothers who had stripping will tell you, oh my gosh, don't do anything, that's terrible, it's painful and it's awful. We have such improvements in treatment these days that Your mom's vein disease, your grandmother's vein disease does not have to be your vein disease, your experience. Spider veins can be the tip of the iceberg for a lot of patients, just that little indicator that there's something going on underneath. So women particularly, if you're in the midst of childbearing and you have a particularly troublesome pregnancy, number 2, 3, where your legs are just heavy and painful, you get big varicosities, you get vulvar varicosities, treat it before you have your 5th or 6th baby. If you're going to go that far, I have people who have 9 and 10 still, because your legs can hold through pregnancy better if you treat in between. This would be one of our patients who obviously is not a cosmetic issue. So when you look at vein disease, this is what guys typically will present with. Yes, they will wait until it is this terrible and awful. They'll just keep wearing longer and longer shorts until one of their wives drags them in and says, please take care of this. But this is why it's not cosmetic. Look at how swollen that leg is. You know, how do you sleep at night and let your legs knock together without, having to wake up and turn over and readjust? So there's swelling and there's pain and there's obviously some redness in this leg. This is not something that is cosmetic. Venous reflux is what causes varicose veins. So when the valves are not working in those veins, there is no heart that pumps blood out of the leg. Your calf muscle, you squeeze your calf muscle, it opens the valves much like the heart, and as your calf muscle relaxes, the valves will close and you'll get progressive upward flow of blood through your leg simply from those valves opening and closing. When those valves don't work properly, either from a genetically poorly made valve, they just kind of get real slow to close, or they don't quite oppose anymore and the vein dilates and the valves wear out, you'll get more and more reflux, very similar to acid reflux, with acid going the wrong way. Now blood is going the wrong way. It collects in the lower part of the leg. You get a congestion, dilated veins, big blue-green veins, and the achy discomfort from having extra volume down there. So when these veins dilate, it's not a straight tube that just fills like a balloon getting bigger. The walls are all different in their strength, and so you get these big, rolly, lumpy, tortuous veins. They get very thick and give you the presentation of that young man's leg that we just looked at. You do not need a vascular surgeon to treat venous insufficiency. Our vascular surgeons are great with arteries. They do a lot of interventions for our diabetics and for folks with arterial disease. They tend to prefer arterial disease and have left the venous sector a little untouched, which is why so many people don't know about venous disease. So a bunch of very smart cardiothoracic doctors, interventional radiologists started investigating more of vein treatment and vein disease. And people like me who were actual surgeons, like pelvic surgeons, and saw pelvic vein disease, have gone into doing more of endovenous treatment. And it's a vein specialist that you need. So there's not necessarily just the vascular surgeon that you need to see. Those guys tend to be really busy doing a lot of surgeries in the hospitals, and the vein disease sector has pulled out a little bit separate from vascular surgery. Most of them are very happy with that, and then we actually have a couple vascular surgeons who actually work with us because they prefer the vein side. So it's a big mix of different specialists that do vein treatment. What you need is advanced education and training to do endovenous treatment. Compression stockings are a good way to control symptoms. They help reduce pain and swelling, but they don't treat veins, varicose veins. They won't make them go away. Once they are dilated and you have congestion in your leg, treating the veins is what's going to make things feel better. The myth that men don't get varicose veins is a huge misconception. That man's leg that I showed a couple slides ago, he's about 40 years old. Think about what that would look like at 70. And a lot of guys will wait a very long time before they come in because they just think that they're cosmetic, if you believe that. Wives don't think it's cosmetic. We usually honestly have wives dragging their husbands in, but it's definitely a problem for men as well as women. And varicose veins don't necessarily recur, but you can get new veins. Once they're treated, the treatments hold about 95% of the time. So unless there's something else going on that causes a recurrence, we're really good these days with seeing treatment hold. So this is what a leg will look like after treatment. So that big bulky varicosity that ran all the way down the back and the inside of his leg now looks nice and normal. That's about 90 days out. So the redness is gone, the swelling is down, the varicosity is gone, and he was actually a cyclist. What brought him in was that he actually caught one of those varicose veins on like a briar as he was riding by something and started bleeding all over the place. And he scared the life out of his friends, who finally said, "Yo, dude, maybe you want to get that fixed." And so now he's not going to bleed on the trail anymore, and he's very happy with that. The way we treat with heat, either a radiofrequency catheter or a laser catheter. It goes inside of the vein, and it treats that vein from inside. So the thermal damage will close that vein. So similar to stripping, where the vein is removed from the circulation, this will close that vein down, but you get to keep it inside. Your body will break it down and it will dissolve. And you don't have incisions all the way down your leg. You don't have the pain and the bruising and the recovery that you would have from stripping, but you get the same effect where that faulty vein is taken out of the circulation. These are superficial veins above the level of the muscle, so they are not the deep veins. There's a very redundant system of superficial veins, and you do not miss this malfunctioning vein for anything except for symptoms of venous insufficiency. We also use VenaSeal, which is a cyanoacrylate. It's an adhesive, so very similar to a glue, if you will. We put drops of that adhesive on the inside of the vein. We take the catheter out and just compress it. You just hold it like you do adhesive anywhere else. The nice thing about VenaSeal, it's one shot of local anesthetic. The adhesive goes in, the catheter comes out, and you could go running that night. So there's not really any downtime at all with this. With the catheter-based procedures, the heat procedures, we ask that you take it a little easy for the 2 weeks. You can be up walking, 10,000 steps a day, just not running or pounding on your legs. So this is a little nicer for our athletes. Varithena is a chemical compound, and that goes into more tortuous and shorter length veins. This is a much nicer way of treating some of the average size to slightly larger varicose veins without having to cut and pull sections of those veins out. This is something done under ultrasound guidance, and the needle that we use is a very small diameter needle. You don't even need a local anesthetic for it. You wear a compression wrap for 48 hours afterward and your stockings for 10 or 12 days following, and they heal a little bit slower than if you just cut and pull them all out, but there's no scarring, and it actually works very nicely. It's nice and clean. We also can, I jumped a little bit too fast there. Sorry about that. We also do phlebectomy. So that young man, because his varicose veins were so big, we did a couple spots of phlebectomy. And phlebectomy just means taking out vein segments that are very large and lumpy. Not 22 incisions down his leg, but like on the slide here where there are 3 little stars, you can make a tiny little incision. That little crochet hook type thing that is in the picture there is a very, very small caliber hook, even smaller than a crochet hook. And the incision is big enough just to allow that through. So when these are all done, you have just tiny little pinholes that we can take big vein segments out of. And we remove the bigger segments without stripping the whole thing out. And the rest of the vein underneath will retract and your body will dissolve that away. So this is very nice for larger varicose veins. The one in the picture we wouldn't necessarily do a phlebectomy for. These days we have Varithena, and that's a nicer option for that vein. So spider veins we get a lot of questions for. If you don't have underlying venous disease, spider veins can be just an annoying little cosmetic problem. Right in the skin, they can cause some itching or burning. If you don't have the tired, achy, heavy, crampy swelling along with the spider veins, then you're not likely to have underlying venous disease and they're not necessarily the tip of any iceberg. They're just unsightly. And those can actually be treated very easily with injections. When you do spider vein injections, you have to have someone who's done a lot of them because it's an art form. You have to look and identify where the optimal place is to inject. You have to have a nice steady hand, and you have to have experience with how much medication to inject, because the medication goes in this vein. It causes a chemical irritation that blocks that vein or causes occlusion of that vein, and then your body will dissolve and break that vein down. It takes some time, so you can't have them injected on Tuesday and wear a mini skirt on Saturday and expect that you're not going to have any residual spider veins. These can take 10 to 12 weeks to dissolve completely. And when they do dissolve, you can go from the picture on the left to the picture on the right. That is 3 months later after injection. That leg looks pretty good when you look at it from a distance. And this lady was very happy with how these look. If you look very closely, you can see that there are still some very fine little spider veins left underneath her knee there, and just above her knee on the lateral side of her thigh. They're really fine. They're very tiny compared to what she started with. So everybody's a little different in what their expectations are. This could still undergo another session of sclerotherapy to get those little hair-like spider veins that are left. But again, much better. And her main complaint was that they itched and they burned, and she didn't want to wear shorts or a skirt because she felt like her legs aged her. Pelvic pain, something that a lot of people know about. So we're going to switch gears a little bit. Chronic pelvic pain, if your gynecologist has worked you up and your gastroenterologist has worked you up and you're just at a pain relief stage, there is still something more to offer with regards to investigating pelvic pain. A lot of patients, when they get to the, gosh, we just don't know what's going on, we can't find anything, will end up on pain medication. They have gone to lots of different specialties. They've gone to the gynecologist, the gastroenterologist, they've seen a general surgeon, they've seen an endocrinologist, trying to find some reason for their pelvic pain. So there's more opportunity to be on pain medications, to get non-gynecologic procedures like colonoscopies, upper endoscopies, laparoscopies. And chronic pelvic pain is a significant problem for a lot of women. They end up being very unhappy. There's depression, there's pain medication use, there's pain medication abuse, and it really diminishes quality of life for a lot of women. It actually can interfere with the quality of a relationship. If you're having pain after intercourse, pain with intercourse, it's hard to keep a loving relationship at times because our counterparts can feel that we're avoiding them, or there's a problem with the relationship and not something physical. So it can lead to real problems with quality of life that should not just be left to wait for menopause, which a lot of gynecologic pain is often, oh, let's wait till your hormones change over and see how menopause goes. If you're 35 or 42 years old, that's a long time to wait. So pelvic pain of venous origin presents much like just chronic pelvic pain of many etiologies. Pelvic pain of venous origin is the new term for the old school term pelvic congestion. It causes the same dull, achy, lower abdominal pelvic pain. It's usually better if you're laying down, which is not practical if you're a mom and you've got kids running around and you have to get everybody up for school and get yourself out to work. There's pain after intercourse, there's bladder irritability, leg pain, heaviness, fullness, general discomfort, and it's often taken to the gynecologist first, which is appropriate. The big takeaway from this is that it's primarily a pain for women. Reproductive years, 20 to 45, at least 2 pregnancies. The 3rd pregnancy seems to be the tipping point for most women who develop pelvic vein disease. And if you have pelvic pain problems, bladder problems, and you've been to the gynecologist and they haven't given you an adequate diagnosis, you really owe it to yourself to come in and be investigated for pelvic pain of venous origin, because it's crazy common. When you look at what the testing is for this, you start with a pelvic ultrasound. Do you have any fibroids, you have ovarian cysts, is there something else going on in the abdomen or pelvis that could be causing compression in there that is responsible for your symptoms? If you've been through that, most everybody with chronic pelvic pain has had an ultrasound. You get a pelvic venous ultrasound, and that looks then at the veins in the pelvis and not just the ovaries and the uterus and the bladder. Some people have had CAT scans. A CAT scan or a CT venogram, actually, you use dye to highlight the vascular system to actually look for compression of the veins. And the area that we're looking at is when the veins come up through the legs and they meet in the midline, just below the belly button. The artery sits on top of the vein, and that artery pulsates on top of that vein for your whole lifetime. You throw a couple pregnant uteruses on that over time, and you can actually get an area that is compressed. That compressed area you can see on a pelvic venous ultrasound. You can see even better on an intravenous ultrasound. So that center picture, that black and white, that is an intravenous ultrasound. There is an ultrasound on the tip of a catheter that's put inside the vein, and that big black circle is actually the diameter of the vein that you see. So you can pull this down gradually all the way through the vein until you find the spot that's compressed. The venogram picture over on the far right, on the left, so stage right, for us it's left, but you see that there's a white area where the two veins separate, and it looks a little pancaked, it's a little flat. That's actually that crush spot in the vein. If you can we move our
We can.
So we're looking at ourselves a little bit. So if you look at the area where that branch comes down on the right hand side, and you see that there's this tortuous curly little vein that's coming, that's a varicosity. So it's like putting your foot on that vein and holding it there, and you increase the pressure downstream. It's harder for the blood to come out, and so you dilate all these other little pelvic veins because the blood is trying to get around that area. And that's where pelvic congestion comes from, is these pelvic varices. But these varicose veins actually come from that crush spot in the iliac vein. So that's why pelvic pain of venous origin is the new title for that. Yeah, and we'll change our picture back. So when you have compression of that iliac vein on the left-hand side, the problem comes in what it's leaning against. So there's no give in that area, because if you look from the side, top to bottom, that compressed vein is right on top of the spine. So you've got bone right behind that vein. There's nowhere for this vein to expand, and it just continues to get crushed and flattened. Putting a stent in that vein will hold it open, and that is what you need. You need strength in that vein to keep it open so that that compressed area doesn't cause the symptoms of congestion any longer. And that's done with sedation in a vascular lab. So not something we do as an outpatient in our clinic, but certainly doesn't even need going to the operating room for. There's not cutting and surgery for that. It's a procedure. You put a catheter inside, there's a balloon that goes over the catheter, the stent slides over. It's very sleek, very cool. And things to do preventatively, like everything, maximize your physical activity, your body weight. It's not that being obese will cause you to have varicose veins or cause you to have pelvic congestion, but your symptoms are more when you have more abdominal girth to work against to bring blood and fluid up and out of your lower extremities. If you are a good body weight, you're healthy, wearing compression stockings if you're sitting for long periods of time, especially with COVID and working from home, we see a lot of folks with swelling. Getting up, getting moving, maximizing your leg health, your muscles in your legs, and particularly during pregnancies, wearing compression to maximize return of blood out of your legs is going to diminish that work that your legs have to do, and it will diminish the amount of congestion you get if you do have venous insufficiency, so that you will hopefully not dilate those veins as big and bad as they could be. So that is pretty much what I have to say today, and I'm happy to answer any questions.
Thank you so much. That's great. That's us again. Well, thank you. That was really, really interesting to hear. And as somebody who has a lot of varicose veins in the family, I have been particularly interested in this topic just to see what can be done. I've heard about various treatments over time. And I think what's changed in the last maybe 10 years is that we really should all feel a lot more comfortable about treating.
Absolutely.
These.
Yeah.
You know, lots of people talk about, oh, I have it, I hate it, but it's not that bad. I'm not going to do anything about it. And, you know, they wait and wait and wait and wait. And I think what you're trying to tell us is that it's really not necessary to wait. It's a safe treatment. It's an effective treatment. You could literally, since 90+% of the blood return comes through that central vein back up to the heart, you can literally treat all of the superficial veins without causing worsening swelling, more symptoms, any kind of problem down the road for people.
Pretty much.
It literally is just a way to manage those veins that gets rid of them for a good long while, and often for, you know, forever. We know it's a chronic disease, so there's always a chance that there might be new symptoms coming up. But I think this is really something that has changed. Our awareness has changed significantly,
which is a good thing. And to be completely open, when I was looking at the connection between pelvic pain of venous origin as a gynecologist, and I was working as a consultant doing some of the referrals to Center for Vascular Medicine for the treatment of pelvic pain, I had cramping in my legs. And I had talked to many doctors. I mean, we sit in the hospital all the time. You chat with people. Nobody had an idea. Oh, magnesium, lose weight, drink more water. I wasn't even this weight when I was in the hospital, which is, 30 pounds heavier maybe. And it wasn't until one of the vein docs said, you probably have venous insufficiency. And they found that they treated it. My cramping stopped. I would get up at 3:30 every morning for years with Charlie horses that were so bad. Even if I wasn't on call, I wasn't getting good sleep. And I was not a nice person, which is a real problem. But they treated it, and I thought it shouldn't be this hard to find out what's going on and to treat it. And it's not. So I really believe in what I do because I know it works. And these procedures are covered by insurance. So every different insurance company has different policies on what numbers or how many veins you have or what type of procedures they may prefer one over the other. And we are really good about keeping track of who's covering what and what procedure. So, do you do a laser versus a radiofrequency or a venous seal? That may depend on your insurance company, but based on your vein, your insurance, your symptoms, these are covered by your insurance. And it's easy enough to come in, we map you out, we give you a plan, and we always clear everything with the insurance company first. My staff is very good about knowing what your copayment would be or what your policy may ask you with regards to, a time frame that you have to complete the procedures in.
That's helpful. I think that's another thing that people worry about is will they ever actually be able to get it covered?
Exactly.
Because it's not purely cosmetic anymore. And the risk of doing nothing is progression to worse and worse varicose veins, swelling of the ankles, and ultimately even slow ulceration, wound healing, ulcers, and that skin, the dryness and itching of the skin.
So I always use this as an example. When you walk around the supermarkets in the summertime and you see folks who have really deep, dark brown ankles, their skin is getting very dry, very peely, if you will. That's advanced varicose vein disease. That skin change increases your risk for ulceration, and ulcers are painful and they're harder to heal than they are to prevent. Varicose veins, like that young man,
months to go.
Oh away, yeah. I mean, months and months. I mean, 6 to 9 months, a year sometimes. The larger varicose veins actually increase your risk for a blood clot because you can get stasis or slow down of the blood. It kind of sits in there. It can get red and hot and hard. Phlebitis. If you talk with grandma, she knows what that is. But it's it's a superficial clot that can actually extend into the deep system, and then deep venous thrombosis, and that can actually lead to real trauma in your leg long term. So yeah, there's a lot to prevent.
Sure, we have any other questions? Let's see. Is there anything else that you wanted to cover that we didn't touch on?
I think if you have it in your family, if you know mom has varicose veins or dad has varicose veins, one parent, you have a 45% chance of having venous insufficiency in your lifetime. Two parents, and it's about 90%. The degree is different, but most people will have something going on in their legs. And once we talk to folks and say, well, do you sit down, put your legs up at the end of the day because you're beat, your legs need the break? A lot of people don't even assign that as, significant. So if you have it in your family, come on in. And the scan itself takes about 45 minutes. The consultation takes about a half an hour. So if you schedule about 2 hours just to get your mapping and get an idea of what's going on, get a plan, then depending on what procedures are indicated, we'll make that plan. We schedule you for it, and we are open 7 to 5, so we can do them very early in the morning. We can do them during your lunchtime, however it works for you. The bigger procedures may take an hour from door to door between the time you change, come in, get your scan, chat with everybody, get the procedure done and go home. Or it can be as quick as 25 minutes for an injection. Because we do these under local anesthetic, we get to know people really well, and sometimes we chat a little longer than other times. So your procedure may take a little bit more time depending on what we're talking about that day. But the procedures are really generally quick, and we break them up into pieces so that we're not going to traumatize your legs so much in one day that you can't get up and walk out. So you're up and walking right out of the procedure room.
So just to give people a sense for what a typical visit is like, they come, they check in, you've met with them at one point and had the initial scan so that you already know what the treatment plan is going to look like. And then you schedule various treatments, and you can do as many as 2 treatments a week, it sounds like. And then they come in, you get rescanned after, if you've done some work already on that leg, right? You'll double check it at the beginning.
Exactly.
And then we'll just make sure that there are no deep vein clots, no other problems that might be arising, or no other reason why a procedure shouldn't be done.
Right.
And that's just a few minutes. And then the treatment actually takes place, and it doesn't hurt. They numb you, right? So there's not, you might feel a little bit of a stick initially with the numbing medicine, but otherwise it's really not a terribly painful process. Then they wrap your legs up tight afterward and ask you to go for a walk.
Yes.
Right?
Exactly.
And after you keep the wrap on with some tight compression from the wrap for 1 or 2 days, depending on which procedure you've done. And then after that, you ask people to wear the stronger strength compression stockings for
usually
10,
a
10
week
days.
to 10 days. Yeah.
And then after that, sometimes people don't even really need like the lighter strength compression stockings for a while, right? The need for the compression stocking can actually go away.
Yes.
And which I think is pretty amazing. Although then again, people have to decide if they have jobs where they're on their feet all the time, they're standing for long periods of time, or there's just an increased risk of having the vein disease come back. Then that's where the support stockings might come in handy on a chronic basis.
Yeah, most of us who do vein disease, we actually wear compression stockings, not just because the reps give us stockings, but because they give your legs a little bit more stamina, and they're a little, they're less tired at the end of the day. And hopefully preventatively, there hasn't been a good study that said, it absolutely prevents you ever getting recurrent disease, but it seems to delay the onset of symptoms. So if you can hold anything off, it's worth doing with the compression stockings. And there are a lot of nice ones out there these days, so you don't have to wear grandpa's support hose. So it works really well. We often equate this to kind of like going to the dentist to get your teeth cleaned. Because if we just say going to the dentist, a lot of people don't like going to the dentist. It doesn't hurt like getting a cavity filled necessarily, but it's very easy. to walk in, have the procedure done, and walk out. So you're not sedated. You don't need a driver. You're back to your life.
I learned the compression socks or stockings trick when I was a resident running around the hospital all the time, when I suddenly realized how many of the nurses are wearing them.
Yeah.
Because when you're busy, active, on your feet a lot, you're long hours, 12-hour shifts, whatever, the stockings really can, as you said, they just feel good.
Yeah. So, nurses are very smart people.
Yeah, they are.
Yeah.
All right. Well, this has been terrific. I really appreciate your time and your knowledge and your willingness to share all of this with us today. And we will look forward to maybe bringing you back on other topics at some point in the future.
Oh, that'd be great. No, I'm very happy to share this. Like I said, it shouldn't take people years to find out that this is actually a manageable problem, and you don't have to sit at home with your legs elevated, or not go out to your kid's baseball game and be able to sit through a game because your legs hurt. One of my best friends actually came in to see me, and she said, "You know how I always got up and walked around during the kids' games? I thought you were just antsy." She said, "No, my legs were cramping. They were killing me." And she never said anything. She knows what I do, and she never said anything. So we fixed her up, and
she may not have ever made the connection. I'm not sure I would think about cramping legs being.
Yep. Yeah. It was, believe it or not, it was her husband, after coaching with my husband, who said, "Oh, Carlos said that maybe it could be." And so my husband's done a lot of good referral work for me. Yeah.
And you have several office locations,
yes.
right? You're one of the offices is here in our building, here in the Yorktown 50 building in Merrifield.
Right.
But you also have offices in a couple of other locations too. And where
so
are those?
Me personally, I work in Fredericksburg and in Fairfax. We have an office with Dr. Michelle Nguyen in the Reston Hernan area and Manassas. We have Dr. Seema Kumar in Leesburg. We have Dr. Priya Thermalai in Alexandria. And we have Dr. Richard Nguyen in Woodbridge. So we're 98% women in Northern Virginia. Dr. Nguyen is great, though. We allow him to be part of the club. But all of Virginia is covered. We actually go down to Virginia Beach and Suffolk. Dr. Nichols is down there. We have clinics in, I think it's about 12 different states. So if you're looking for something in Connecticut, New Jersey, New York, Maryland, DC, we have Indiana, Michigan, Alaska, Arizona, New Mexico, Georgia, Florida, and Alabama, South Carolina. We haven't hit North Carolina or California yet, but we're looking.
Lots of good choices. That's great.
Yeah, so there are a lot of places. And if you have symptoms, if you have family members who have symptoms, it's an easy evaluation. It's an ultrasound, and it's an ultrasound of your legs. So, pair of shorts, an ultrasound, and a talk, and it's not painful. It gives you a lot of good information.
It's terrific. And we love having you in the building. It's so nice for my patients. They just go up a couple of flights of stairs and they're there.
Perfect.
So,
great.
Well, terrific. All right. Well, thank you all for tuning in. Thank you for your questions. We really appreciate your time today. And just as a reminder, I'm Eileen West. This is Dr. Theresa Soto from the Center for Vein Restoration, and I'm a general internist in Fairfax, Virginia. I have a concierge internal medicine practice that's focused on women's health. So if you ever think that you might be looking for that, look us up, give us a call. Thank you so much. Take care. Until next time.
All right. Have a good night.